Hey guys, Dr. Dustin here. This is another episode of the Dr. Dustin Show, and tonight we are going to react to a video sent in by one of you. Now, I wasn't going to react to this, but there's a lot of points in there I think that I need to address perhaps from my perspective. This video is entitled, Why Doctors Won't Prescribe Opioids. And as an opioid prescribing doctor, I wanted to know what other people thought why I wouldn't want to prescribe it. This video is, of course, created by Dr. Simon Fang. I hope I'm pronouncing that correctly. And from what I could tell, he is an anesthesiologist, pain management specialist out of Indiana. And so, well, let's just get into what he has to say here. Why doctors won't prescribe opioids.
I would like to apologize to my followers on TikTok because I have not posted anything on TikTok for about 2 months. In that time frame, I've even shaved my head.
I did too, but I didn't have the commitment. Looks good on you though, Dr. Fang.
The reason I haven't posted anything is because when I filed my taxes for 2025, it became apparent that my pain management clinic lost $60,000 last year. This is the clearest way to demonstrate why patients are having so much trouble finding doctors who are willing to prescribe opioids. It simply doesn't pay. A majority of my patients with chronic pain are no longer able to work, and they have come to rely on Medicaid and even SNAP benefits just to survive. Medicaid reimbursements for office visits for pain management is pitiful. It sucks.
That's true.
That's why I've lost $60,000 last year. The only way for pain management to make money is to push patients towards injections, radiofrequency ablations, spinal cord stimulators, pain pumps, or surgery. That's why your pain doctor keeps pushing these things on you even though they don't really help your pain long term.
Wow.
They might make your pain worse.
Okay. Well, I mean, medications don't help your pain long term either, about, maybe 4 to 6 hours per pill. So it's something you have to maintain. But again, it depends on what your goals of care are, right? What's interesting here is that he's saying it doesn't pay to write prescriptions. That's why your doctor keeps putting you towards procedures. Well, let's think about that just for a second, because we've talked about this before. Medicare will reimburse an epidural steroid injection around $100, depending on where you are, sometimes a little more, sometimes a little less. But let's just say on average about $100. But an office visit is $125. Now, if you think about the volume of interactions that you have, encounters that you have as a physician, about 20 patients a day, let's say 5 days a week, that's 100 patients. Nobody's doing 100 injections a week. Maybe 20, maybe 30 per week is still, I would consider that to be a very high procedure volume clinic. And so not only is the reimbursement lower on average for the average procedure, which is probably an epidural steroid injection, is most commonly done, but the volume is also less. So mathematically, it just doesn't add up. Definitely there's money to be made in office visits, in prescribing. That is the bread and butter of keeping the lights on in the clinic. Now, it's true what he's saying about Medicaid reimbursements. It's no secret, unfortunately, Medicaid reimbursements are quite low. And if that's all you were depending on to keep the clinic alive, the clinic would not survive. But still, on average, across let's say a broad payer mix, the office visit is the bread and butter. And so I don't see the money driver being the reason why we're pushing patients toward procedures. It just doesn't add up.
Everything in medicine today is geared towards making money. And prescribing pain pills for pain simply doesn't pay. Furthermore, every prescription for opioids that I write takes away profits from interventional pain doctors, from hospitals, and from biotech companies. You know this because you know that you're far less likely to turn to these procedures if you could get adequate pain relief through pain medications. Interventional pain doctors,
So he's making a point here that as a patient, he believes that you would much rather choose pain relief through medications than through, let's say, interventions. And certainly there's patients that would go that route, but I know a lot of patients just want to be fixed. I mean, leave a comment if you just want to get better and stop going to the doctor, right? That's where, interventions may play a role, because I see very often where injections, nerve blocks, even stimulators can help reduce a patient's dependence on medication, free them up again to live a life that is not dependent on prescriptions and seeing the doctor. So, I think it's different strokes for different folks, right? And it depends on what your goals of care are, and what your treatment is for the right patient at the right time for the right reason. And so again, it's more nuanced than prescriptions good, procedures bad, or vice versa.
Hospitals and biotech companies make far more money when you are not allowed to have pain medicines. Sadly, these are the people with the political power and the lobbyists to make sure that they demonize opioids and tell you how dangerous they are, even though the vast majority of people who die from opioid overdoses these days are dying from illegal fentanyl and not from prescription pain pills.
So that's true, but we have to think about how we got here. Going back to the good old days, early 2000s, when heroin was the big thing, it's up to 80% of people who were abusing or overdosing on heroin. Up to 80% of those were first abusing prescription opioid medications, whether directly prescribed to them or getting the medicine from a family member or a friend. So that's still a consideration today. You can't just say, oh, well, people are dying of, fentanyl, illicit fentanyl, so opioids are safe. Again, how did we get here? And it's more nuanced than just saying that, I think, by itself.
15 or 20 years ago, there was a lot of dirty money being made pushing OxyContin and other brand name pain medications. That's not the case today. Today, pain meds are mostly generic and there's very little profit left in them. All the big money now is in procedures. In my opinion, the money being made from pain right now is just as greedy, just as dirty, and harmful, but somehow it's legal now.
Yeah, again, that opinion I would definitely agree with if it's directed toward physicians who are weaponizing procedures, and we all know who you are. If you're sort of using it as a carrot or as a way to control what your patient does, because patients still need autonomy. There needs to be an agreement to the plan of care. I'm not saying that as a physician telling another physician you have to do whatever the patient tells you. If you're uncomfortable just writing opioids because of however you decide to treat their pain, then that needs to be agreed on up front. But it's not good to do a procedure just for the sake of keeping the DEA off your back, or to enforce your patient to get a procedure so that you can be compliant or whatever. It's just forcing anybody to do anything is not appropriate. And so decisions in medicine, especially with plans of care in this nature, need to be agreed upon ahead of time. And yeah, it's very common and probably appropriate to have a multi-pronged approach to your pain, just because we're complex creatures. Pain is complex, and oftentimes it takes more than just one pill targeting one particular receptor. But yeah, it's definitely a nuanced conversation to have, and well, let's keep listening because there's more to this.
What's the answer? Well, for me, the answer is to shift to a nurse practitioner or physician assistant-based practice, because NPs and PAs are able to work for half to 1/3 of the cost of a physician.
By the way, that's where everything's going. Everything's going to nurse practitioners and physician assistants. Even though the administrative monstrosity that is part of healthcare takes up, most of the cost associated with it, everyone likes to point their fingers at doctors. So doctors are slowly fading into administrative roles, and nurse practitioners and physician assistants are going to be the front line. Just give it a few more years.
We also need to take advantage of an economy of scale to be able to practice without losing money. That's my plan, to keep my practice afloat, because my patients need us.
Yes, that is true. And that might work in Indiana. We can't do that in Texas. Nurse practitioners and physician assistants cannot write for Schedule II medication, so it's still going to take a physician. But let me just conclude with this. Why doctors won't prescribe opioids? It's not because it doesn't pay. Obviously, I'm not as practiced as Dr. Fang is. I've been in practice for almost 6 years now, owning and operating my own clinic. And I can tell you, by and large, despite all these brand new fancy procedures that come out and I get trained on and we select the right patient for and all of this, the volume is not there to make any significant difference. If we took away procedures, the clinic would be just fine. If we took away prescribing, the clinic would disappear. So that's just the bottom line. It's not because of money that we don't want to prescribe opioids. Actually, the real reason is the same exact reason you as a patient might feel apprehensive going to a doctor to ask for opioids, and that is the stigma involved in it. Yes, physicians have stigma too. We have to defend that prescription to not only you, but your family members, to the pharmacist, to other physicians in the region who refers patients to us. We have to defend that prescription to the state, and we have to defend it to a lawyer, and hopefully not to a coroner in case something bad were to happen. So we live and die by that prescription, and it takes a lot of effort to defend it. And for most folks, it's just easier to throw a needle and call it a day. Well, that's my take on it. And as you can see, it's a much more nuanced conversation than opioids good, procedures bad. The way I like to practice is taking an individualized approach and using all the tools in the toolbox to make sure that we can help you live more with less pain as quickly and safely as possible. Dr. Fang, good luck with your practice up in Indiana. Until then, peace.